Thank you, Chairman and Co-Chairperson. Thank you, Dr. Sirisha and Dr. Padmasri, for making an extraordinary effort of conducting this conference and making this conference a source of knowledge with good speakers. I thank Dr. Sirisha and Padmasri for their effort. Before I proceed on to the lecture, I have taken the topic of endometrium because seldom we assess the endometrium, we assess only the uterus. And in this journey of 30 minutes, I will be telling you the different facets that are associated with endometrium in relation to assisted reproduction and how endometrium and assisted reproduction is evolving over the years. When you exactly look at the cause for assisted reproductive failure, it boils down to only three conditions: the sperm and the egg, and then you produce an embryo. Then the next thing is your transfer technique. The third is the endometrium or the receptivity. It boils down to only those three factors: how good is your embryo, how good is your transfer technique, and how receptive is your endometrium. And this makes a difference on the implantation rate, live birth rate, and the whole field of reproductive medicine boils down to only to these 3 points. So here I am concentrating only on the endometrium aspect, not the transfer, not the embryo, not the sperm. In this lecture, I will be dividing my topic into a brief introduction of window of implantation, what are the modalities we have in assessing the endometrium prior to the IVF, during the IVF cycle, what if we have a pathology and what is the impact of that pathology on the endometrium, and then after there is a failure of a cycle, if you find certain information, how are you going to do a workup, what is within our perspective and what is not within our perspective. That is what I am going to discuss in this talk. When we look at the embryo implantation, it boils down to three critical events: apposition, the adhesion, the invasion. The apposition part is an unstable part wherein your uterine and the endometrial contractility will alter the implantation rate. The adhesions depend on the signaling of the mother, that's the endometrium signaling to the embryo, and the embryo signaling to the uterus. And then you can come to the most important part, that is the invasion and the subsequent decidualization that happens, which have been translated into an area called window implantation. And even after so many years, we still do not understand every mechanism that is involved in the window of implantation, because we have not studied the basic mechanisms that are involved in the apposition, adhesion and invasion of embryos. So that is the becoming the black box, and that is where the combination of genomics, metabolomics, proteomics and microbiomics are unraveling the answer. So if you look at the decidualization, that's the invasion, a lot of transformation occurs, and this transformation is occurring in a fibroblast which is becoming, and work was done, and even a concept of fetal transplant is coming into place to replace the microbiome. When it comes to a uterus, initially it was thought only there is a vaginal microbiome but no cervical microbiome, and uterus is a sterile environment. But the answer is no. But the scientific community, following the Human Microbiome Project, which has been published in 2016, is making us understand the various types of microbiome that are available in the human body. And these changes in the colonization will affect the following areas. One is it affects the interleukins, it affects the pattern recognition receptors, it affects the T helper cells and the Treg regulators. So one should be cautious when they give an antibiotic, because there is no role for prophylactic antibiotic in a beginning of a cycle in IVF. We end up giving multiple antibiotics, multiple antifungal agents. In the process, we are destroying the normal microbiome, that is the lactobacillus, and we don't realize it because we don't have any markers to test it. It's only a question of time. In the next 2-3 years, we'll have people offering microbiome services. In fact, in US there's a website which is already offering vaginal microbiome for different dysbiosis, and also they're contemplating to offer uterine microbiome. So in the next 5 years, 3 to 4 years, you'll see a lot of information on the microbiome. And as reproductive medicine specialists, all of you should get familiar with this concept and then understand it. Then when we come to the uterus, here we are having a lot of confusion about the thickness of the endometrium, the volume of the endometrium, and the vascularity. So when you look at the thickness of the endometrium, this is a nomogram where they are given the spread of the endometrium from 11 to 15 millimeters, wherein they have emphasized one thing. The endometrium, if it is on the lower side, it does not reflect a hormone environment. Sometimes when the endometrium is lower, we tend to increase the dose of the estrogens, not realizing the good amount of cervical secretions and push up the endometrium. We have to look at the pathology that is behind a smaller, thinner endometrium, whether the uterine volume is proportionate to that, whether the junctional zone is being affected or that, whether the vascularity is affected or not. That's how you should look at endometrium thickness. And endometrial volume, because it has an observed variability and a machine variability, it is generally not become a standard procedure. Similarly, the advent of Doppler, because it's person dependent and machine dependent, so there are no standard values. So the world got stuck in the area of endometrium by only looking at endometrial thickness. In the uterus, unless you carefully look for an abnormal endometrium, you might miss synechiae, and then you might have a thinner endometrium and then think that the endometrium is slightly thin and I didn't have an implantation. So a proper workup of the endometrium before an IVF cycle is very important. Similarly, what is the role of hysteroscopy? When should we perform hysteroscopy? As you see in this figure, a micropolyposis, this you might miss it in an ultrasound, and then you might pick it up at a later point. We have been practicing routine hysteroscopy since 2004, and this has been reflected in this publication, wherein assessment of uterine cavity by hysteroscopy in assisted reproduction and influence on pregnancy outcomes, where we found close to 37% of minor or major abnormalities which are missed at the ultrasound. In 2007, the quality of ultrasounds are different. Now they are vastly improved. Still there is scope for hysteroscopy, and I'll justify why in the coming slide. We might miss a thicker endometrium with a synechiae or a polyp unless you repeat the scan in the follicular phase. That is where you can do a correction, but it depends on the practice you're planning. We at Krishna follow to do a hysteroscopy for any given cycle, but does not mean we do it for every cycle. So in 2016, we have a review and a meta-analysis of the last 10 to 10 years of data, and we were fortunate enough to have our work being cited as one of the citations. In this review, they found that up to 40% one can find minor or major abnormalities in an IVF failure cycle when you do a hysteroscopy. And our data showed close to 37%. And just like how Sesh Kamal has said, if your work has still relevance a decade later, then it's an important work. Because the work we did was in 2006 and still is being cited even now because that had relevance. But there is a conflict of opinion because we in India are treating an IVF for an infertility patient. But when you look at Europe, some of them move to IVF to reduce the time to conception. Suppose in a Scandinavian country, where the country promotes them to go for IVF quickly to increase their population. That is a different population set compared to an Indian population, say, where we are dealing with an infertile patient who is coming for IVF. Seldom we get a patient who is directly going for an IVF to reduce the time to conception. So one should look at the population in which the recommendations are coming in. As I mentioned, that paper says it allows the diagnosis of unsuspected intrauterine abnormalities in infertile women in almost 50%, and our data at that time showed that is 31%. And there is also some argument saying that it works like a scratch test, but I am not very sure that is true or not, but that's the explanation the scientific community gives. Because till now, people are able to show that scratch test gives a benefit, but they are not sure how it gives a benefit. And the final word of role of scratching the endometrium is not said, but one of the explanations people say of histoscopy, post-histoscopy better pregnancy rates is scratch test, but I am not sure. But I believe in the vascular patterns, the micropolyposis, the endometrial pathology are the important key factors that make a difference. The other area where we should concentrate, which we seldom concentrate of the endometrial cavity, is in a post-cesarean section woman. In a post-cesarean section woman, we take it for granted that the uterus is normal because she had a baby. We take it for granted and look for endocrine causes. But in the last 5 years, the concept of the niche as a cause for infertility is coming up. And so do concentrate on the cervical uterine junction, look for areas of defects, and look for any fluid in the cavity, and that might give you that your cesarean scar can be the cause for infertility. This is a major progress that has happened in the last 5 years, where they found that scar as a cause for secondary infertility is being identified as one of the major causes in a secondary infertility following a post-cesarean section. That you can identify by having a good 2D or preferably a 3D ultrasound, where you find these areas of defects called niches, and then that niche, if it is bigger, then the need for correction is there, and if it has a fluid in the cavity, more so, that is the cause for the secondary infertility. But this is one area of endometrium in a post-cesarean section. We don't practice it as a routine. So I urge everybody to look for any scar defects in the myometrium which is linking to the endometrial cavity. That might be one of the precipitating clue for you to do a further workup of the endometrium. This is for a cesarean section scar. In the endometrium, during an IVF cycle, apart from the length of the endometrium and the thickness of the endometrium, there is an evolving concept called the junctional zone, which is the area wherein the major changes occur. That's the area where the spiral arteries undergo transformation, the whole decidual reaction happens. That can be also the cause for the pathology of preeclampsia. And we, along with Samson, worked in this area and then did longitudinal studies of the junctional zone throughout the cycle. Here in this study, what we did was, we assessed the junctional zone every time we did a scan, and what we found was the blue lines are the non-pregnant women, the orange lines are the blue lines are the pregnant women, the orange lines are the non-pregnant women, and this is in the right lateral, left the fundal area and the average values. What one realizes is junctional zone is it's not a static space. It keeps on changing throughout the menstrual cycle, and the rate of progress of that junctional zone increase is different in an implantation and a non-implantation. And I'm happy to share that this work was quoted in the last yesterday in one of the talks. They were trying to correlate the role of junctional zone into implantation failure. One thing is, here the junctional zone does not cross 10 millimeters, which falls into the classic endomyosis. Here the junctional zone is falling above 3.5 millimeters, where the chance of implantation is not happening. And there in the talk, they correlated with the NK cell abnormalities and the other areas. So this is an evolving area which, apart from endometrial thickness, might become one of the standard measurements of future. When you have pathologies of the endometrial cavity, there are two things. In the area of septum, there is a radical change is happening that every septum need not be corrected. That's a going debate. Earlier it was any septum, a hysteroscopic resection was done. Now there is an emphasis that not all septums need correction and not all septums are cause for a pregnancy loss and more so an implantation failure. So there is a rethinking on the role of septum in the area of the endometrial cavity. In the area of unicorn uterus or the malformations, one should accept there is a limitation in the performance of that uterus, and at this moment the unicorn uterus, there aren't any good solutions available. Of endometrial assessment is there, the vascularity, junctional and everything is there, but the implantation rates that are happening in a unicorn uterus are vastly different. That is what an information one should use in their counseling. When you come to polyps, endomyosis and fibroids, earlier for many years we thought polyp is caused by a mechanical obstruction and acts like a property, but evidence is showing that it affects the Hox gene and in turn changes the other markers of the glycogen, aromatase and inflammatory markers and reduces the mRNA of Hox 10 and 11 genes, so in turn changes the protein. So a polyp once upon a time was thought as a mechanical failure need not be a mechanical failure. So one should, before an IVF cycle, if there is a polyp, the current recommendations are to do a polypectomy. And when you look at multiple polypectomies, the recommendations are, apart from polypectomy, look at the endometrial pathology, whether any glandular structure abnormality is there, and then wait for a couple of cycles and then plan and look at the recurrence rate in multiple polyps, which is radically different recommendation for a single polyp. So the area says if you find a polyp, don't consider it a mechanical event. It also has an effect on the mRNA. If it is multiple polyps, wait for a cycle, recheck whether all the polyps are removed, then look at the pathology, whether the pathology has cystoglandular hyperplasia on the polyp surfaces. There, the role of waiting for a couple of cycles to see that the polyps does not return and then planning a cycle. In the area of endomyosis, as all of you know, it's a disruption of junctional zone, but using a bulky uterus, using a 3D function will help you to pick up the endomyosis more accurately, because if you look at on the left side image, it looks like a bulky uterus but no fibroid. But when you apply a crystal view, which is featured in the GE or the Samson ultrasound machine, you see this is a uterine cavity and this is the area where the junctional zone breach has happened, and then you're seeing the endomyoma. So the breach of junctional zone, this you will see in a hysteroscopy as punctum, and there you see sometimes blood or black fluid dropping in. And if the blood and black fluid are dropping in during hysteroscopy, go back and look at your uterine cavity, either by a 3D ultrasound or MRI, and then confirm your diagnosis of an endomyosis, because your implantation rate changes in that, and by telling the patient, you have less problem at the result review. Whether when you look at subnuchal fibroid, the classification of 0, 1 and 2, which affects the endometrial cavity, the uniform recommendations are to correct the fibroid. But when it comes to multiple fibroids like this, there is conflicting evidence, which I will be showing you. On the left side, where they are showing negative effect is there are 8 to 10 publications are there. On the right side, where there is no effect, we see 5 publications. So the jury about when to do a myomectomy, which is not larger but in the intramural cavity, not affecting the endometrium, there is no clear-cut guidelines of which one to follow, and it's up to the individual clinician to take a call in their what is best in their practice. There is nothing called wrong or right, because you see so many articles, one saying there is a negative effect on implantation, intramural fibroid, On the right side, you have 5 articles saying a fibroid does not affect. So if somebody does a myomectomy, don't be judgmental because it can be based on one aspect of the evidence. When the endometrium has failed, then you might have a perfectly normal endometrium, then you have a thin endometrium. If it is a thin endometrium, a lot of times we increase the dose of estrogens, but it will not help because the concept of thin endometrium is poorly understood. Its significance is not clear, as I will be showing in the evidence in the next slide. Here you see almost different strategies, endocrine strategies, vitamin supplementation strategies, surgical strategies. The orange is unclear effects, the green is beneficial intervention, the red is no intervention. In a thin endometrium, except for doing a hysteroscopy, the evidence does not show the other interventions are not very effective. But only time will tell us that area. The other area of improvement that is coming in is the role of stem cell in the area of the thinner endometrium. But the final word has not been said, but it's not PRP. They are looking at transformed stem cells into endometrioid cells which they are transferring, but it's not PRP. So finally, when we come to recurrent implantation failure in endometrium, first of all, look at whether the embryo is good, whether your initial assessment of the endometrium, did you miss anything? Then only look for the last two things, the immunological factors and the thrombophilic factors, because unless we are supposed to screen the first two acquired abnormalities and the endometrial factors at the time of evaluation before you start the IVF cycle, and the last two can be done in repeated implantation failures. The carry home message is give importance to endometrium at the first visit. The second thing is when you're planning an IVF cycle, give importance to the endometrial assessment and use appropriate tools to pick up such abnormalities. Then, if you have a failure, then look for the immunological factor, but not immunological factor as a first factor. I thank one and all for the patient here.